All right. Hello, everyone. Welcome to a subspecialty case discussion. My name is Maddie Conti, and I'll be facilitating the discussion today. The subspecialty of focus today is GI, and I'm really excited to have two wonderful educators here to help discuss this case. So I'm going to go through their introductions. So first we have Dr. Shreya Patel. Um, Dr. Patel, she is currently an assistant professor at UCSF based at Zuckerberg San Francisco General Hospital, where she serves as Director of Quality Improvement and Innovation, as well as an assistant program director for the GI Fellowship Program. Her focus is on colon cancer screening efforts in underserved populations utilizing EMR-based registries, automation, and low-cost technology output. So Shreya, thank you so much for being here. We're really excited to learn from you. And I was wondering if you could tell us a little bit about how you developed your interest in GI and specifically colon cancer screening. And then apart from that, also something that brought you joy this past week outside of medicine.
Sure. So I was a primary care resident and did a lot of work in global health. And so I've tried to find a specialty that really combined my interest in preventative care and population health along with procedures. And that really found me in GI. And colon cancer screening is something that affects everybody. And so I just found it was a really great way to have a huge impact on the population. So I get to interact both with the individual patient, kind of doing their procedure and talking with them, and then also thinking about how I can affect an entire kind of city's health or an entire population's health. So that's what landed me in GI. And then in terms of something that brought me joy, we have had some wintry weather here in San Francisco, but I was able to escape this weekend with my two children and get outside and play around in the park, and that brought me a lot of joy.
Amazing. Well, thank you so much for being here. And our other case discussant today is Dr. Max Brondfield. So he's a third-year fellow in GI at UCSF. He completed his medical school, IM residency, and chief residency at UCSF before entering his GI fellowship, where he currently serves as chief of diversity, equity, and inclusion for the fellowship. He'll be staying on at UCSF as an assistant professor in the division of GI next year with a focus in general GI and medical education. And his clinical interests include inflammatory bowel disease and functional GI disorders, including irritable bowel syndrome. His passion is training the next generation of doctors to be excellent gastroenterologists. So Max, thank you also so much for being here. And I'm curious if you could share a little bit about how you developed your clinical interests focusing on inflammatory bowel disease, and also what brought you joy this past week.
Yeah, absolutely, and thanks for having me. You'll hear a similar theme as what Shrey spoke to. That balance of doing procedures and also working with patients is a really appealing part of GI. And so for me, the clinical interests were things like inflammatory bowel disease, where you have a chronic condition where you have to build a long-standing relationship with a patient, but have some interventions and evolving exciting therapies that can actually make a difference for them. So I love that balance of getting to work with patients long term, but having procedural interventions and effective therapies. So I found it to be a really exciting field. It's been a lot of fun so far through fellowship. Looking forward to the next few years. And something that brought me joy, yes, also I think there were breaks in the stormy weather, so we got out with my daughter to the zoo this weekend, which is a lot of fun. There's a carousel at the San Francisco Zoo, which is now like a staple of our weekends. So that was a good time.
Oh my gosh, I'm curious, what animal was the highlight from the zoo experience?
Yeah, well, the carousel animal is known as the actual animals, but I think for her, she's really into the flamingos right now. She just
Wow.
thinks I think she tries to copy the one leg stance. We're like, all right.
So fun. Amazing. And we have Promise Lee, a team member who's going to be presenting a case. Promise, do you want to unmute, introduce yourself, and also share something that brought you joy?
Hi everyone. So my name is Promise. I'm a third year medical student at Loyola Strict School of Medicine, and I'm planning to apply to IM next year with hopes of pursuing GI fellowship. Something that brings me joy is honestly, I think that I'm in family medicine right now, and talking to kids are really, really fun.
Amazing. And promise you have yet to do your pediatric rotation. So, we'll see.
Oh, I think I will be laughing every day. They're so cute.
Yeah. Awesome. Well, we can dive into the first aliquot of the case, promise, whenever you're ready.
Okay, so the chief complaint is general life weakness, jaundice, and recent poor oral intake.
All right. So even with just this brief information, Shreya and Max, I'm curious if you could maybe talk through of these different, chief concerns, which one you would focus on, and if you'd kind of have a framework to about how you think about it.
Sorry, happy to get started. So good question, right? We have sort of three different important chief complaints. The one I tend to focus on, just generally speaking, for all cases, I think about what's sort of the one with the narrowest differential and / the most concerning. So weakness and poor PO intake can be the presentation of any number of conditions and are important, but are pretty non-specific. Whereas jaundice is much more specific. Jaundice suggests there's an elevation in bilirubin. We don't know if it's direct or indirect yet, but that's got a much more narrow differential and helps us focus in on some more important stuff. So I'm definitely going to focus on the jaundice. I don't, the differential for jaundice, we'll need a little more information before we dig into it, but that's definitely going to be my focus as I'm hearing the start of the case.
Amazing. And Shreya, I'm curious, besides the branch point of direct versus indirect for approaching jaundice, is there a different way you think about the differential diagnosis?
Yeah, whenever I start with someone with jaundice, we're kind of assuming that their total bilirubin is elevated. So yes, what you said in terms of deciding if it's direct or indirect is helpful, but I try to break it also down to within the liver or outside of the liver. So intrahepatic or extrahepatic. Intrahepatic is going to lead me down a different route, something that's affecting the actual hepatocytes within the liver, whereas extrahepatic is going to be more of a structural issue typically. So we're affecting the bile ducts so that the bile production is happening, but it's not exiting the liver and getting into the intestines in a normal fashion. So that's kind of a big, broad buckets that I try to put things into.
All right, fantastic. Well, promise you can take us through the HPI.
Yeah, thanks for the branch point discussion. So this is a 72-year-old female with CAD, diabetes type 2, hypertension, hyperlipidemia, who present to the ED with complaints of weakness, jaundice, and poor oral intake. She said that about 3 days ago, she had 1 day of chills, nausea, vomiting, abdominal pain that all resolved on its own. But the weakness progressed to the point where she slipped out of bed in the morning and could not get up on her own, which prompted a visit to the ED. She denied any head injury, trauma, denies fever, chills, chest pain, shortness of breath, dysuria, hematuria, weight loss, dysphagia, melena, hematochezia, diarrhea, rashes, or swelling. There's no recent travel or sick contact, and she denies any alcohol use. I'm also going to go ahead and to give the rest of the history and then go into the physical exam, if that's okay. So for medications, she said she takes supplements including B12, zinc, vitamin C, magnesium, folate, and lemon balm. But per family, the patient is only compliant with omeprazole, metoprolol, lisinopril, sitagliptin, metformin, and she stopped taking amlodipine and prasugrel. They're unsure if she takes aspirin, chlorthalidone, Plavix, except that's the cholesterol medication. I can type in chat, and then insulin glargine because she's inconsistent with home medications. And then for family history, the mother is diagnosed with pancreatic cancer around 70 years old. Maternal uncle was diagnosed with cholangiocarcinoma. Allergies wise, she's allergic to statin and she gets severe myopathy. And then vitals, the temperature is, I can go ahead and pause a little bit.
Yeah, promise. Why don't you we can pause here because we have a lot of really great information, and maybe I'll come to Shreya first and just hear how this HPI is affecting how you're thinking of the patient and if we can make any progress on the origin of the jaundice.
Yeah, I mean, I think things that stand out to me as a specialist. So I try to kind of think about all of her past medical history that probably is unrelated off to the side. So things like coronary disease and diabetes and hypertension, that's all there and that's fine. But I'm kind of trying to focus, like Max was saying, on what's unique or what might stand out. So her age is the first thing that I start to think about. So people in their 7th, 8th decade of life, we start to think, unfortunately, about malignancy as higher on the differential. And someone who's coming in with jaundice, there's many different malignancies that can affect the pancreaticobiliary tree that can cause jaundice, unfortunately. So that would be pretty high. There was mention of family history of pancreaticobiliary cancer as well. So that might raise the suspicion a little bit. We don't typically think of them as kind of direct family inherited, but possibly. But other than that, I don't really have a lot thus far to narrow things down. But malignancy is probably something that I'm worried a lot about just because of the 2 points that I already mentioned. I do think always about meds when, you guys went through her med list, especially in someone with jaundice, lots of different medications, especially over-the-counter medications, can affect the liver in ways that people don't realize. And so it's great that whoever was taking this history got a really thorough medication list, including both prescription and non-prescription medications. There's a great resource in the US called Liver Talks that I would point people to. It's an online free resource through the National Library of Medicine. And really, you can look up almost any medication and kind of find how it affects the liver and what the pattern of LFT abnormalities that you see is. So sometimes when things come up that I haven't heard of, like lemon balm, and I don't know if it's going to affect the liver, that's the first place I look to see if there's any case reports.
Fantastic, thank you. I've also never heard of lemon balm. Not quite sure what that is. And Max, I'll come to you. Before we get to the physical exam and the vitals, I'm curious what you tend to focus on when doing the physical exam in someone who has jaundice.
Yeah, so we can talk about the physical exam. And one piece I'll add, I think that will help guide a bit, is one thing I think is also important in addition to everything Shreya brought up is the time course can be helpful too, focusing on the fact. So this is a relatively acute presentation. We hear about someone who, as far as we know, investigate more, but doesn't have a history of cirrhosis or chronic liver disease that we know about, had this acute episode 3 days ago with chills, vomiting, and now is coming in with, jaundice. And so that certainly worries me, like what acute insult is happening. And that will help guide my physical exam because things I'll look for in general, some of it will be, sequelae of chronic liver disease, classic signs of cirrhosis, things like ascites, pulmonary erythema, spider angioma on the skin, sign, things like that might suggest more chronic liver disease. But I actually am not expecting a lot of that here because we're hearing a relatively acute presentation. And so then if you're worrying about an acute presentation with jaundice, you then have to make sure, are we talking about acute liver failure or not? That's our big number one sort of urgent question on the exam. Like, does this person look like they are encephalopathic or heading towards a really acute presentation? Or is this, like Shreya said, maybe more of a malignancy where there's been an indolent sort of course? So first, chronic stigmata liver disease is important to look for, but not totally consistent with her presentation. We've had many patients where the first time they present to the hospital, it turns out they have cirrhosis, so it doesn't by any means rule it out. So chronic sequelae of liver disease are one thing, but I'm looking first and foremost for sort of, is this an emergent situation? Are they having signs of impending liver failure? So that's encephalopathy, mental status are going to be two of the most important things. We'll certainly look for things like jaundice, signs of volume overload as mentioned, but my number 1, 2, and 3 is going to be like, what is their mental status? Do they have HE? Am I heading towards an ICU admission?
All right, thank you. That's really helpful. Actually, before we go forward and given that you focused on the time course and saying that you're a little bit more concerned with this being acute liver failure rather than chronic, what are some of the most common causes of acute liver failure that you think of?
Yeah, great. And one clarifying thing, this is so important because this comes up a lot. So acute liver failure is a very specific condition and sort of an emergent condition. I'm more worried about an acute liver injury, and these two things are important to distinguish and review. So when we think about someone coming in with new jaundice, we'll look at our LFTs in a moment. But if someone has elevated LFTs and even potentially coagulopathy, some synthetic dysfunction, they can have an acute liver injury, which can be caused by a number of things. Then acute liver failure is those findings plus altered mental status. Someone who's starting to develop encephalopathy, and that's like an emergent ICU level indication. So acute liver failure is a very specific and concerning diagnosis. I'm thinking more initially about, what could be cause of acute liver injury. And so that differential, what can cause acute liver, it is going to depend a little bit on the LFTs and the pattern. We tend to break things down into, transaminitis, elevated AST and ALT versus more of a cholestatic picture, which have some overlap in the differential, but are somewhat different. So if someone coming in with jaundice, I'm leaning towards the cholestatic liver injury picture. The LFTs will help guide us further. But it's things like Shreya said, either there's an intrahepatic cause, something where the liver is not functioning well. That can be medications, toxins, things like that, versus there's something obstructive in the bile ducts, either a mass like a tumor or a stone or something like that. So fairly broad differential. I'm leaning towards cholestatic liver injury. We'll see the LFTs will help guide us a bit there. And then just reviewing again, acute liver failure is a very specific presentation with altered mental status that's emergent. So that's why the exam will help us with that. And then we'll think about acute liver injury based on the labs.
Amazing, fantastic teaching, and thank you for clarifying the difference between acute liver injury versus failure. All right, Promise, we can jump into the physical exam now.
Okay, so for temperature, 98.6, heart rate 70, blood pressure 198/81, respiratory rate 20, and she's sitting on room air with 96% oxygen. And then in terms of the physical exam, she is alert and oriented ×4. She just complains of generalized discomfort. HENT, there's scleroicterus. Cardiopulmonary exam is normal. Abdominal exam, soft, mildly tender in epigastrum with no rebound tenderness or guarding. Non-distended, normal bowel sounds. Neurologic exam, cranial nerve 2 to 12 grossly intact, no focal neurologic deficits. And extremity exam, she's able to walk without any assistance. And with skin exam, she's jaundiced, no rashes, bruises, or lesions.
All right, well, maybe this time we'll come to Max first to get your initial thoughts on this physical exam.
Yeah, great. So a couple of things we had talked about, right? So first, assessing the mental status. We hear about ANO ×4, interactive. We didn't hear about any asterixis or signs of encephalopathy. So reassuring again that we're not looking at someone who has altered mental status or potential acute liver failure right now. So that's reassuring. We have time to sort of step back and think more about what could be causing liver injury. We certainly see two signs of jaundice. We have scleral icterus, so the eyes are yellow and the skin is jaundiced. Generally, it can vary, but you expect the bilirubin has to get up to a decent level, to start having scleral icterus. And I expect it to certainly be above normal, and probably well above 4 to see that. And otherwise, the exam is fairly non-specific, but in a reassuring way. We don't hear about ascites or big distension of the abdomen. I think in the chat, Promise added no stigmata of cirrhosis, like no spider angioma or anything like that. So again, consistent with what we've heard so far, this is likely an acute presentation. But so overall, again, the exam reassuring in terms of not liver failure, but certainly hypertension and signs of jaundice. So I'm concerned there's some cholestasis going on.
Fantastic. And Shreya, anything else to add before we get some initial labs?
No, I agree. I think I would definitely ask if I was hearing this presentation for asterixis, like Max was saying. So just remember when you're evaluating for that, you have the patient put their hands out completely, like they're stopping traffic, and typically close their eyes. And you're looking for a very characteristic flap of the hand. You can sometimes elicit it a little bit by placing your hand on the patient's and bending it backwards a little bit. And that kind of produces it in your hand. And so you can feel that beat. It's going to be different than someone undergoing withdrawal who has like a true tremor or a Parkinson's tremor. So those are the things where you would actually see kind of a side to side movement of the hand compared to a flapping. So actually truly assessing for asterixis is probably the first question I'm going to ask my fellow when they call me about this patient.
All right, fantastic. Promise we can jump into the next aliquot.
Okay, do you want to stop at labs or do you want to also go into some imaging?
How about we just do labs and then we can analyze that before imaging?
Okay, sounds good. So for labs, the white blood cell count is 12.2 thousand, and then hemoglobin is 13, platelets 122, and then chemistry, sodium 128, potassium 4.8, chloride 93, CO2 is 19, BUN 16, and then creatinine 0.69, glucose 240, calcium 9.9, AST is 100, ALT is 140, alpha is 129, total bilirubin 5.7, and direct bilirubin 2.5. We also tested lipase, which is negative, and we did an acute hep panel in the ED, and that was negative. And then we also sent 2 tubes of blood cultures.
Okay, so with these initial labs, Shreya, how can we make progress on the jaundice?
Yeah, so I think this is pretty helpful to show that her transaminases, so the AST, ALT, while certainly slightly elevated, are not the predominant abnormality here. So you can see that her bilirubin, and especially the direct component, which really just helps us narrow in that this is not from hemolysis, this is coming from her liver, does show that there's kind of some sort of pattern going on within the actual livers or right outside. So I'm not sure that this completely tells me if it's intrahepatic or extrahepatic. It's more likely extrahepatic, just given that the bilirubin is so high. But the alk phos is a little bit lower than I kind of would expect for kind of a true cholestatic picture. So this is someone that I think imaging would be really helpful.
And could you talk a little bit about which imaging you start with in a patient like this?
Yeah, I think it's always dependent on the exact situation, the stability of the patient, and kind of how high our level of suspicion is. For something like this, I would probably just head straight to cross-sectional imaging with a CT scan. The kind of order of imaging I generally think about when I'm looking at the pancreaticobiliary tree is ultrasound is kind of the quickest and dirtiest. So maybe not the most sensitive exam, but it's something that will give us a quick answer typically. So if someone's sick or I just really need to get a sense of what's going on, that's probably where I would start. CT is obviously going to be a little bit more sensitive. So we're going to get better imaging, especially of the biliary tree, of the pancreas. And then last would kind of be an MRI. So an MRI is going to give us very detailed looks, especially at the biliary tree, the pancreatic duct, the soft tissues, and kind of all of the surrounding structures. And but it's a much longer exam. And so, it's not necessarily the first one that I would start with.
Great. And Max, anything else to add about these labs before we get imaging?
No, I agree. I think we're in that sort of non-specific range, sort of Shreya alluded to. It certainly is cholestasis predominant. The AST and ALT are not super high, but the bili is not so high that we have sort of a narrow differential. Actually, can be a lot of things that cause the bili to be up like this. So we still have a broad differential. I'll just add, on that point, again, we had someone who initially had sort of nausea, vomiting, abdominal pain, chills, like any number of infections could actually cause this, as sort of a bystander of someone being sick. We think about some degree of cholestasis with sepsis. This person is not in septic shock by any means. I just mean to say that the differential is quite broad. A lot of things can get your bili up a little bit. So it'll be helpful. Some imaging will be helpful, and we can talk about additional testing in a bit too. But I would definitely start with some imaging now.
All right, and we had a question that with the AST and ALT at this level, if you could comment a little bit more on the differential diagnosis you're considering.
Yeah, sure. So exactly. So the AST and ALT are above normal, and everyone, all labs vary a little bit. AST, anything often above, for both of them, really anything above 40 to 50 is definitely elevated. These aren't quite, the ALT is just about 3 times the upper limit of normal, which is often a threshold we'll use for like true elevation. But again, that can be, this degree of elevation can be sort of a bystander to any number of causes of liver inflammation. So if there is a biliary problem, if there's cholestasis, that stasis of bile can actually irritate the liver and lead to an elevation in AST and ALT. So they're actually very non-specific elevations. So I'd say our differential remains quite broad. At this low level, what becomes less likely, and this is, we can briefly review, so what are the sort of causes of acute severe transaminitis that we're not suspecting in this level? Acute viral hepatitis, we'd expect AST and ALT to be much higher. Toxic exposure like Tylenol toxicity, we expect them to be much higher, if it's acute. So the sort of classic sort of toxins, viral hepatitis, and then actually an acute stone can sometimes make them rise higher, but the stone remains on the differential because the bili is up. But I'd say we're not looking at these sort of acute transaminitis causes. Shock liver would be the other one. Again, no suspicion of that in her anyway. But those are things that would make your AST and ALT up to like 1,000. So those are more off the table with this pattern. But this degree of elevation is quite nonspecific.
Got it. Thank you so much. All right, Promise, we can move on to the initial imaging.
Okay, so we got the CT abdomen pelvis, and it shows thrombosis of the left portal vein branches. Remainder of the portal venous system appears widely patterned. Cholelithiasis extending to the cystic duct. Mild pericholecystic fluid is nonspecific for cholecystitis. Suspected cholelithiasis with diffuse enhancement of the extrahepatic biliary ducts, which can be seen with ascending cholangitis.
All right, so maybe I'll pass the mic first to Max to talk about the findings from the CT scan.
Yeah, great. So CT was a good choice. Good quick assessment of the biliary tree and everything surrounding. So a couple things. So we heard about cholelithiasis. So there's a lot of chole words. I used to get them very confused as a student and a resident. But cholelithiasis, so stones in the gallbladder. So that's just gallstones, which can be a routine finding in a lot of people. Extending to the cystic duct just tells us that a stone could get impacted, could cause cholecystitis, infection of the gallbladder. But we're also hearing about here is suspected choledocholithiasis. So choledocho referring to a stone in the duct. So it's made it out of the gallbladder into the biliary tree, and that's when we get worried about obstructing stones, causing infection like cholangitis. So what we're hearing about here is potentially a stone that started in the gallbladder, made its way into the bile ducts, and then got stuck. And we're seeing diffuse enhancement, which could suggest, inflammation consistent with cholangitis, inflammation of the bile ducts, which is can be a severe infection. And we can talk, in terms of getting into some of these radiology findings, we often equivocate a lot in GI about what does enhancement of the bile duct on CT really mean? Is that definitive for cholangitis? We really consider cholangitis to be a clinical diagnosis. We need a constellation of symptoms and labs to make that diagnosis. So the imaging, you will sometimes see enhancement, and it doesn't mean there is always cholangitis. But in someone who reported, abdominal pain previously, has an elevated bilirubin and these findings, that's a pretty good story for cholangitis, or at the very least, obstructive choledocholithiasis that may become cholangitis soon.
And Shreya, I'll pass the mic to you to hear you after these CT findings. How would you move forward with next steps here?
Yeah, so radiology is basically telling me as the gastroenterologist that they're worried that there's a stone in the common bile duct. And I think we have enough evidence here, like Max was saying, to be pretty concerned about cholangitis. Well, she's not febrile, and she doesn't, I think her white count was just slightly elevated or like kind of low normal. She's older and has comorbidities and is coming in with chills. So it does make me concerned that this is choledocholithiasis with some brewing cholangitis. And so really the next steps for her would be to probably take her straight to ERCP. And the way we decide that is there are actually criteria put forth by one of our gastroenterology societies, ASGE, that everyone should kind of look up before they do their GI rotation, because you use them all the time. But it basically breaks people down into a high, medium, or low risk of having a true stone in their common bile duct. So someone who's at high risk has a pretty elevated bilirubin, so typically greater than 4, and dilated CBD on imaging, or they have a clinical diagnosis of cholangitis, or they actually have a visualized stone on imaging. So if anybody falls into those three categories, which she would, because I think we're going to kind of clinically call her cholangitis, or at least pretty close to it, she definitely has a bilirubin greater than 4. And while they didn't specifically talk about the dilation of her CBD, the fact that they said suspected choledocho, makes me think that either they saw a stone or they saw something dilated. So she has enough. That means that she has a pretty high risk of having a CBD stone, and we would take her straight to endoscopic therapy to help remove that stone. There's a lot that needs to be done for her medically, though, also. So she needs to be treated like she has a source of infection and is in sepsis. So she would be given IV fluids, she'd be given IV antibiotics, kind of depending on how her vitals look. She could be monitored in the ICU if she needed to, versus kind of closely on a telemetry floor. Oh, and the blood cultures are a great idea too.
Awesome. And one thing I wanted to go back to is you both talked about cholangitis and it being specifically a clinical diagnosis. And I was wondering if you could both talk more just kind of explicitly, like what factors go into you calling or giving someone that label of cholangitis.
Yeah, so there's sort of classically a triad and a pentad. I'm not a huge fan of eponyms. You just memorizing it, but I think the triad that is really applicable. Charcot's triad's name, but this idea of fever, right upper quadrant pain, and jaundice was the classic triad. Before we had labs and imaging, but that triad is still very useful. Because we'll see, as Shreya already mentioned, we often rely on the bilirubin, as one of our main cutoffs. Bilirubin and imaging as two ways of seeing if people are sort of low, medium, or high risk. But as you're sort of waiting for your imaging, that triad of sort of fever, right upper quadrant pain, and jaundice is still a pretty good predictor for, could this be cholangitis? We will really rely on that. And again, because sometimes we'll get these CT reports sort of in the absence of those findings. So if there's maybe a question of a stone, or more commonly, if there's a question that the bile duct might be dilated with no stone, and we'll get a question, could there be an obstruction here? If someone has no fever and no symptoms, just a dilated duct, we think about that very differently than someone who's coming in with right upper quadrant pain, fever, jaundice. So that clinical presentation is really important to us in understanding what the risk is here, because imaging alone can be deceiving.
Great, thank you. Okay, Promise, we can move forward with the next aliquot.
Okay, so the ED, they consulted general surgery, and then general surgery recommended a interventional GI consult, and then they will evaluate for possible cholecystectomy. Interventional GI actually recommended MRCP, and then the primary team, so we started Sulsin because we're concerned for developing ascending cholangitis. At that time, the blood culture was still waiting. So the MRCP was done overnight, and then that showed a 5 millimeter filling defect within the distal common bile duct consistent with cholelithiasis and no biliary duct dilatation. And then we also got the blood cultures back, and one of the two grew Enterobacter cholacea, and so we switched from Sulsin to cefepime based on susceptibility, and then we also repeated the cultures, and then we consulted ID, and then they recommended adding a flagell for intra-abdominal coverage. And then we have ERCP that was planned, but the patient's blood pressure was persistently elevated, so that was postponed. And at that time, her alphos, LFT beliefs were all elevated. And we also did an abdominal ultrasound to evaluate possible portal vein thrombosis, which came back saying that there was no evidence of central vein, portal vein thrombosis. Should I go ahead and talk about ERCP, or should I stop here, Maddie?
Maybe we can stop here and get the thoughts. Maybe we can start with Max first about what your thinking is on kind of the sequence of events.
Yeah, great. And so, yeah, a lot to unpack. And again, so much of this, when we talk about it, there's so much that varies case by case and hospital by hospital in terms of logistics and things like that. So some of the comments we'll make, there are many different ways to do this. But one thing that Shreya had alluded to, based on the CT findings and the clinical picture, we probably wouldn't have bothered with the MRCP because this patient already met criteria for ERCP. So to be clear, an MRCP is an MRI scan that MRI cholangiopancreatography. So just like we would do an ERCP and shoot contrast into the bile ducts, this is an MRI scan, focusing on the bile ducts and can be the most highly sensitive for stones. So it's great. It's a really great test, especially looking for a small stone like a 5 mm stone. It's a good option. But if you already suspect cholangitis and you already have seen a likely stone on CT, it's reasonable to go to the test that's also a therapeutic intervention. And the reason we like ERCP so much is it's both a cholangiogram, we shoot dye to make a diagnostic evaluation, but we can also remove the stone at the same time. So either way, but in this case, we might have gone straight to ERCP, but it's helpful that we have this great imaging test. And in many cases, when it's more equivocal, that can be very useful. So great, we confirmed our stone, we confirmed blood culture's growing, Enterobacter, which can very well be a biliary/GI bug. So all consistent with this picture that this irritation of a stone passing through the bile ducts led to, transient or continued bacteremia. So appropriate antibiotics are great. And then there was this question of, the next time I think I see a question in the chat too about, concern about the blood pressure. So we can actually, I'll spend a minute saying, a couple things about ERCP and cholangitis. One is that we used to, prior to the days of my training, it used to be considered a medical emergency, like this quote unquote pus under pressure, like you sometimes hear with urolithiasis as well. And we've really moved away from that because antibiotic treatment and supportive care is so effective. And we actually find sometimes that taking somebody who's bacteremic and immediately accessing their purulent bile ducts can sometimes make people actually very sick. So the good news in this case is it's not unreasonable. If there are concerns, generally speaking, about the procedure or the patient's stability, supporting with antibiotics for a day or two is totally fine and totally reasonable clinical care, assuming they're continuing to look stable. So in this case, doing antibiotic, it's not like some bad was done by waiting on the ERCP if the patient was looking good and getting appropriate antibiotics based on their blood cultures. So supportive care is fine, at the outset. It's not necessarily an urgent thing to go to ERCP. So I think that's all well and good, but at some point it is important to relieve this, this obstruction because things can actually get worse. So I do think an ERCP is indicated. So what we'll say, the last part I'll say is, while there's no rush, when they're doing well with antibiotics, if the patient is hypertensive, but we think the procedure is indicated, this would not keep us from doing the procedure, if it was necessary. But again, every situation is different. I'm sure the team was making a thoughtful global assessment, and thankfully antibiotics, it's not inappropriate to use antibiotics and sort of support the patient through an initial period.
Thank you. And Shreya, just wanted to turn to you to see if you had any other thoughts about the kind of course of events and MRCP versus ERCP use.
Yeah, again, it's mostly logistical, honestly. There's time of day and ability of each hospital and what the system's pattern is. There are kind of like best practices and guidelines that are being put forth into trying to make sure that resources are used pretty thoughtfully in these patients, because in the past, like Max was saying, these patients can sometimes go through every imaging technique, and then they get an ultrasound, then they get a CT, and then they get an MR, and then they get an ERCP, and then they get a surgery consult. And so trying to streamline that is where we can kind of use these predictive models to say who is at low, medium, or high risk for a stone, and then kind of treat them accordingly. So, I think this sequence of events is pretty common, but really in the acute setting, supporting her through what's the, now bacteremia and an infection with a known biliary source is probably the most important step. And then the ERCP is going to be needed, and eventually a cholecystectomy.
Thank you. All right, Promise, back to you.
Okay, so because of her elevated blood pressure being around 180 to 200, her ERCP was postponed by 2 days. So she finally got her ERCP on day 3 of the hospitalizations, and it showed gallstones, colloidal cholelithiasis, status post biliary sphincterotomy, and 1 stone removal. And then interventional GI recommended cholecystectomy after treatment for the portal vein thrombosis, because what happened was whoever read the abdominal ultrasound ended up getting back to our team saying that they think the CT sensitivity for the portal vein thrombosis is higher. And so they think that we should treat for the portal vein thrombosis. And then, so the patient tolerated the procedure without any issues. We started on heparin drip for portal vein thrombosis. At that time, her white blood cells were within normal limits. Her LFTs were improving. Her biliary came down to 2.9, and then she's tolerating diet, and the blood culture has been no growth to date for the next 2 days.
All right, I'll pass the mic to Shreya first this time to talk about this additional information.
Yeah, the portal vein thrombosis is interesting. So we kind of think about portal vein thromboses in two big buckets, so acute versus chronic. Chronic is often seen more in the setting of someone with chronic liver disease like cirrhosis, so that's kind of a different situation. We don't know if she's had any imaging in the past that has shown this, but we'll kind of assume it's acute. Acute portal vein thrombosis typically does have an indication for anticoagulation, but there are various kinds of clot that we can see. So there's clot that's truly just plain bland blood clot. And sometimes we see that in the setting of local inflammation. So if someone comes in with pancreatitis, cholangitis, et cetera, that might be a reason that they develop a clot in that area, and it's all just from local inflammation. If someone has a malignancy in that area, they can have tumor thrombus. If someone has an infection in that area, there's a possible that it's actually truly just a nidus of infection. Just something we actually saw this weekend on the inpatient service. But so I think it's kind of hard to say, honestly. I would probably go back to radiology. I would look at her old scans. I would look at this scan in detail and kind of think about what's going on. In the very, very acute setting, you're mostly just trying to prevent like any clot with anticoagulation. You're trying to prevent progression of the clot, which could then lead to bowel infarction. So it's a little mixed. We don't honestly see this that often. So I would kind of get really to radiology to pin themselves down and kind of see what this is, and whether we would truly want to anticoagulate her or not.
Yeah, thank you for that teaching on acute versus chronic portal vein thrombosis and the different types of clot they could actually be. Max, I wanted to turn it to you to see if you had any thoughts on this clot as a whole, and specifically your thinking on the portal vein thrombosis.
Yeah, so a couple things. Yeah, I think Shreya alluded to. So we think this is more likely an acute clot just based on the presentation, and she has probably a reason to clot, even if we don't know whether the clot is infected clot or bland clot related to nearby inflammation. One way or another, it's likely an acute process, and that does make us more inclined to anticoagulate. The question is, like what's more urgent, anticoagulation of this non-obstructive clot that could grow, or getting her gallbladder out, when she's at risk for sending additional stones into her tree? We do know, or I would say our guidelines do strongly suggest, as folks have alluded to, doing the cholecystectomy during the same hospitalization. We find there are fewer representations if the person leaves with their gallbladder out. So, we do feel relatively strongly about having the cholecystectomy, as soon as the patient's stable to do so. So it becomes a challenging, clinical decision. Sort of what's the bigger priority here? Anticoagulating, which may be, for an acute clot, 3 to 6 months of anticoagulation. Do you want to delay their cholecystectomy for 3 to 6 months, or do you want to get the gallbladder out and then anticoagulate afterwards? So it's actually, that's what makes this an interesting clinical decision. Is the clot itself right now doesn't seem to be posing much risk, and actually whether it's infected clot or bland kind of doesn't matter clinically, because we'll treat, for a course of cholangitis, so they'll get an appropriate course of treatment to disinfect, for lack of a better word, that clot. That clot's unlikely to be an ongoing nidus of infection. But whether it's bland or infected and we treat the infection, how urgent is the anticoagulation? And we're not going to have, this is a clinical decision-making challenge. There's not sort of one obvious right answer. That's one of the most challenging parts of this case, is how do you prioritize gallbladder resection versus anticoagulation? And so the last comment I'll make about that is, so just to review the ERCP, so the whole purpose of this, right, is we, Promise mentioned a biliary sphincterotomy. So what we do is we go in, via endoscopy, we go in through the mouth, find the ampulla, which is in the small intestine, the duodenum, and we can access that with a cannula and make a small cut to allow stones to pass out more easily. If you cut the sphincter muscle, the stones in the common duct can come out, but none of the gallbladder stones are going to come out, right? Those are still trapped in the gallbladder behind the cystic duct, and they could then pass down later on. All we've done is clear out the common duct. So she's at risk for sort of recurrent choledocholitis or cholecystitis, for all the stones that are left behind. So I can't give you, again, one magic answer, but I think we would have to, that'd be a really important, that's why Shreya is talking about going to radiology, getting a really definitive answer about the clot, because whether to defer cholecystectomy or not is an important question.
Fantastic. Thank you both. Okay, Promise, what ended up happening?
So for the initial diagnosis, we diagnosed her with cholelithiasis. And she was like improving. Everything looked like it was going on the right direction after the ERCP. But then the next day, actually overnight, she developed hyperglycemia with blood sugar highest at 400. And then in the morning, she had increased fatigue and altered mental status. Her vitals, it was afebrile, blood pressure was 140 over 60s, pulse was 74, and on physical exam, she was alert and oriented ×3 on rounds. The mental status kind of waxed and waned, and she was answering questions, but very slow. And at that time, there were no focal neurological deficits. Muscle strength was 5 out of 5 bilaterally, able to follow command, no abdominal pain. And then later in the afternoon, her white blood cells start uptrending. She became leukocytosis again, and then she became anemic. So her hemoglobin went down from 11 to 9. And then her sodium was 129, her glucose was 270. Her LFTs and alphos was 9. Alphos was 90, ALT was 31, AST 34, and T-billy is 1.3. So at this point, we have to figure out why is she having an altered mental status.
All right, well, we can go to you, Max, first and get your initial thoughts on this sequence of events.
Yeah, I love a good twist. So you never know. It's tricky. You know, this is a post-procedure patient who's altered. So we have to think about a few things on our differential. You know, it's helpful to have some of those labs. The LFTs are actually getting better. You know, so I think we've relieved that particular obstruction. We did hear about the hemoglobin going down. You know, and some of that can be from fluids. We didn't hear about any melena yet, you know, or blood per rectum. But as we start to work through our differential post-procedure altered mental status, you know, things that we think a lot about is one, is she bleeding? You know, bleeding can make you acutely altered. And we did a sphincterotomy where we cut into her ampulla and cut her sphincter muscle. So a post-sphincterotomy bleed would be a concern, especially if we heard about melena or hematochezia. We have a hemoglobin drop, so bleeding's on the differential. Worsening infection is on the differential. You know, as we discussed earlier, the idea of how urgent is addressing cholangitis. When you muck around in an infected bile duct, you know, you do risk sort of a blooming of that infection or a worsening of the transient bacteremia as you sort of work in an area that's infected. So you also have to wonder about, even though she's on appropriate antibiotics, if she had a transient worsening of her sepsis. We heard about stable vital signs, which is reassuring. But you know, that's always a possibility that things, especially with gram-negative bacteremia, can sort of get worse before they get better because of how acute people react to gram-negative bacteremia. So again, post-procedure concerns: is she bleeding? Did her infection transiently worsen? And the last is, you know, was there a procedural complication like a perforation or pancreatitis? These are the two other big things to worry about after ERCP. She's not, you know, we heard, I actually am forgetting now if she had a repeat abdominal exam, but it sounded like nothing stood out in terms of, you know, peritoneal signs. So perforation is sort of lower on my differential. And pancreatitis, that's just a very common, that's something we worry about with ERCP in general. So all of our ERCPs, we tell patients carry at least a 1% chance of pancreatitis because the pancreatic duct drains along with the common bile duct. And so any work addressing the common bile duct can lead to some nearby edema and then blockage of the pancreatic duct. So we do worry about post-procedure pancreatitis, which can certainly make you altered. So those are the top things that I worry about: is bleeding, transient worsening of infection, and pancreatitis. Perforation is sort of lower on my differential at this point.
Thank you, Shreya. Anything else to, okay, sounds like you're giving the A-okay, but anything else to add?
Nope, Max got all of the main things that we worry about.
Fantastic. Promise, what ended up happening in this case?
Okay, so we were trying to work up the altered mental status, and what we did initially was we did a stat CT head to rule out any neurologic etiology because she was having hypertension, and it was up to like 190s, and then we did a full infectious workup with blood culture, UA, chest x-ray. We even consulted ID to see if there's like cephapamine neurotoxicity. And then the repeated chest x-ray showed the scattered calcified density suspicious for histoplasmosis, but the patient didn't have any kind of respiratory symptoms. So it was kind of low on our suspicion for an active disease. And then we changed cephapamine to start meropenem just in case if that was causing the altered mental status. And then the next day, or actually in the afternoon, the patient developed right facial droop and right upper extremity weakness. And so the CT head showed no acute intracranial process, but was notable for a chronic left basal ganglia stroke. And then we call stroke code for that, and her stroke scale was 12, so that indicates a moderate stroke. Her glucose was in the 300s. She's not a candidate for TPA because it was out of the window, and she's on anticoagulation. The CT perfusion was notable for diffuse hypoperfusion, not a candidate for mechanical thrombectomy because there was no large vessel occlusion on the CT angio. Although the CT angio showed extensive intracranial atherosclerosis disease. And then neuro team said it's okay to continue anticoagulation for her portal vein thrombosis. And then the next day, she has even worsening mental status changes with elevated white blood cell count, progressive anemia, blood sugars in 400s, even though we adjusted the insulin regimen. And then her LFTs start to elevate. And then what happened was she also developed like a bruise in her left abdomen. So we did a CT abdomen pelvis to check for hematoma. And then, sorry, there was a lot of things going on. Okay, and then so we requested for MICU to evaluate her. We updated the family, and then neurology thinks that the changes in the CT is because of global hypoperfusion in the setting of multiple stenosis, and they think that all of these insults with like a developing ascending cholangitis, with hyperglycemia, which is common in like after a procedure, and then with her difficult to control hypertension, bacteremia, and then potentially having a intra-abdominal hematoma altogether. All of these led to a recrudescence of a chronic left frontal and bilateral basal ganglia strokes, and so she was transferred to MICU that night, and then she became obtunded. She developed relative hypotension and AKI. She had new EKG changes with transient AFib, diffuse ST depression, and elevated troponin in the setting of septic shock, and altered mental status concerning for acute coronary syndrome. And her ammonia was elevated to 120, and they did a EGD. So GI was consulted, they did EGD on her, and they didn't find any kind of bleeding. But because she was having like an NSTEMI, and she's pretty much having multi-organ failure, and with her condition, there was not a lot of treatment options for her. And then later in the night, she developed even more neurological symptoms. So there was a stat CT head ordered to find to have a large left ACA and MCA territorial infarcts with cerebral edema, so-called distortion, local mass effect without midline shift or significant ventricular compression, and a small right superior frontal infarct without significant edema or mass effect. And so she was severely hypotensive, requiring 3 pressors overnight after the EGD, along with leukocytosis to 7 decay and metabolic acidosis and elevated lactate. And she unfortunately passed away on day 9 of her hospitalizations. So we like neurology, and like we talked about it, and we think is suspect multiple subacute strokes in both hemisphere, maybe related to like all her metabolic insults, severe hypotension superimposed on like underlying intracranial atherosclerosis disease versus maybe an embolic shower related to atrial fibrillation. And our final diagnosis would be choledocholidiasis, status post ERCP, complicated by developing ascending cholangitis with a course complicated by multiple metabolic insults leading to recrudescence of a chronic left basal ganglia stroke, which led to rapid deterioration with multi-organ failure and multiple subacute strokes in both hemispheres related to severe multi-organ failure in the setting of hypotension.
Wow. A lot of stuff happened, and I'm just so sorry for everything that the patient went through. So this is a lot of information here, but I think I just wanted to turn it over to Shreya and to Max to kind of give maybe 3, takeaway points you wanted to share for this group, given kind of how complicated this case got.
Yeah, I mean, I think I don't know that there is any way to have prevented, unfortunately, like the series of events that unfortunately this patient went through. I'll just say that the cholangitis, especially in an elderly patient, can be a beast. It really can. It's an infection that is linked, like Max said, it's pus under pressure. We're intervening on that, and there is the chance for really bad outcomes. I don't think it sounds like her cholangitis and ERCP directly caused something per se, but I think in the milieu of everything else that was going on, it was probably just a lot for her elderly, body with cardiovascular disease at baseline and untreated hypertension and just a lot of other things that were kind of in the background. So all I would say is, I think take cholangitis seriously. And a lot of it is exactly as this team did, totally appropriately resuscitate her well, start her on antibiotics early, make sure you have good culture data and get her to the procedure. I honestly don't think that the timing of the ERCP even honestly did that much. It sounds like the fact that she was hypertensive to the 200 systolic for 2 days is probably more important, honestly, and getting that under control was probably the right thing to do. So, I think just medical management and then, ERCP when you can for cholangitis, but just taking elderly patients very seriously because they can be frail.
Yeah, thank you. And Max, just wanted to turn to you if you had, 3 kind of takeaway points you wanted to leave for this session.
Sure. And the first one is I would reemphasize that there were a couple questions in the chat about would earlier ERCP have helped or would earlier cholecystectomy have helped. And as Shreya alluded to, I just reemphasize, I actually don't in this case think that would have helped. And in fact, again, we would not advocate for emergently taking folks who are septic, actually benefits them to get them on antibiotics, get them stabilized and resuscitated. Because they can actually have worse outcomes if you rush to this intervention and again have lost some sort of uncontrolled bacteremia. So I really, we can never say for sure what led to this particular set of complicated outcomes, but I don't think her having earlier intervention would have changed the course in this case. And the other takeaway is the importance of the clinical presentation of cholangitis, about the clinical triad, fever, red upper quadrant pain, jaundice, because it's a great case to review sort of the quandary of imaging, right? We talked about sort of various imaging modalities and their relative sensitivity and confusion about the portal vein thrombus and confusion about whether there was a stone or not. And I think it's just a really good reminder that our radiologists are excellent and we have a million great imaging modalities at our disposal, but the clinical presentation is just so important in this disease. So having a high suspicion when someone presents like this for cholangitis would be the other point I'd emphasize. And then, just the importance of appropriate antibiotics, empiric gram-negative coverage up front.
Thank you both so much. And lastly, before we jump into teaching points from Deborah, Promise, was there anything you wanted to share about something you took away from this case, what you learned?
I feel like I learned so much from this case. But I think a couple of things was kind of keeping in mind of some of the some of the research I did was also an atypical presentation of acute cholangitis in elderly, and sometimes they don't present exactly that match the triad or the pentat. So really knowing the specific what Shreya's talked about, knowing high risk, low risk, moderate risk, and then the kind of the criteria, thinking about if they match this, then you can already suspect cholangitis and go ahead and start moving on to treatment, just because of how the severe complication and how quickly patient can deteriorate. And then keeping in mind ERCP, one of the big complications I read from research is pancreatitis, perforation, but also it could irritate the biliary tract to affect worsen the cholangitis. And then in terms of with acute cholangitis, I think something that took away is usually antibiotic alone is not enough, and so you really need to get them to drain the biliary tree and take out the stone and treat that in order to help treat acute cholangitis. And I think I read a study that kind of said like having an earlier intervention would have better, less mortality than later. And so I think with this case, maybe because of the blood pressure and the little delay, that led to, and for her having like risk factors, not being very compliant with medication to begin with, and like her blood pressure was not very well controlled to begin with, that led to kind of like the sequelae later. And then also I thought about reading up a little bit on portal vein thrombosis. It could like usually it's asymptomatic, but if it's a very complete occlusion, then you can present with like abdominal and lumbar pain with sudden onset or progressive development over a few days, and that the complications of that could be like infarction, which we talked about, or like it could grow into multi-organ failure with metabolic acidosis, and sometimes there's also something called portosystemic shunting, which could lead to a subclinical hepatic encephalopathy. So maybe that explained the patient's isolated uremia, and it kind of reviewed a lot about stroke, of how like the biggest like risk factor for her in this case is like the hypertension, and then the post-procedural hyperglycemia, leading to that like recrudescence of this like basal ganglia, like basically a lacunar infarct, which is most commonly due to like chronic hypertensive vasculopathy. And for her, I think it's just a lot of things all together that lead to the outcome.
Yeah. Well, thank you, Promise, for giving those kind of takeaway points. And I really want to thank Dr. Shreya Patel and Dr. Max Brondfield for coming and for just really their phenomenal teaching over this past hour. So thank you so much. And last but not least, we'll just pass the mic to Deborah for some last teaching point summary. And Deborah, the mic is yours.
Yeah, thank you, Promise, for this great case. Thank you, Max and Shreya, for this great discussion. So going like for some quick teaching points, we saw in this case the differential about the acute liver failure and acute liver injury. That the liver failure, it's a concern diagnosis. The patient normally presents with encephalopathy. And the injury, the patient can present with elevated AST, LLT, some disorder in the coagulopathy, and can be like some causes intrahepatic and extrahepatic. And yeah, Dr. Shreya teaches about the asterixis that the patient can present with a very characteristic flap that we can help us to do a differential diagnosis. And about the ERCP, we have like high, medium, and low risk. And in this case, with the bilirubin higher than 4 and a visualized stone, that makes in this case, a patient with the higher risk for doing the ERCP. And then we learn about the post-procedure complication that could be a bleeding, infection, a pancreatitis, and a perforation. And that a patient like in like a more old patient, we can have like different presentation for cholangitis and not with the famous triad. So yeah, that's the summarize of the teaching point. So thank you so much, everyone, for this case.
Thank you. Well, thank you, Shreya. Thank you, Max, again, and hope everyone has a great rest of your night.
Thanks, everybody.
Thank you, everyone. Bye.